For years, cardiovascular medicine is focused on treating heart attacks after they've happened. But what if some of the most important therapies emerging today are actually preventing cardiovascular events even before they occur? Now, what's remarkable is that medications originally developed for diabetes and sugar control are now producing cardiovascular outcome data that many cardiologists and other physicians throughout the world would have considered difficult to imagine a decade ago. Maybe the future of cardiovascular therapy is truly targeting metabolism. Welcome to The Six Health, Conversations with Dr. Subodh Verma. This is the GLP-1 MasterClass, clear conversations about what matters most in cardiometabolic medicine. These are expert opinions. These are real experts. This is real clinical impact and patient impact. I hope you enjoy. On today's show, I'm truly delighted and privileged to welcome Professor Darren McGuire. Darren has been not only a maven, but he's been a real friend for the last several decades. He's internationally recognized as a cardiologist, as a clinical trialist. He's a professor of medicine at UT Southwestern Medical Center, and actually has been one of the architects behind the entire story of how diabetes medications have transcended from being medications for sugar control to becoming formidable pillars of cardiovascular protection. Professor McGuire, Darren, thank you so much for joining us today.
Hello, Professor Verma. Subodh. It's great to be with you, as always. Thank you.
Well, thank you, Darren. So let's get started. You know, many patients and people living with diabetes and people living with obesity and cardiometabolic disease still think that overweight and obesity and diabetes are primarily issues of blood sugar and weight. But isn't the real danger cardiovascular disease?
Yeah, it is, and you and I have known each other for decades, but let me take you back to 1997, when as a resident at UT Southwestern, I made the completely serendipitous discovery that we had no idea about not only efficacy, but even the safety of the medicines we were using to treat type 2 diabetes. And at that time, all we had at the time was insulin and sulfonylureas. And so with this emerging disease around the world, there was this incredible unmet need. And now I wish I could say I was smart and saw all this coming. But the timing was just right. As I went into cardiology fellowship, diabetes was beginning to take off. It was about 2% prevalent when I started. We're talking about 15% of the North American population now. And we had to know the safety at a minimum and ultimately the cardiovascular efficacy of the medications we were using to treat glucose. Glucose control, before we get into this conversation, glucose control is important for microvascular disease risk, but we just had no idea about the cardiovascular implications of the medications we were using, both for atherosclerotic cardiovascular disease, heart failure, atrial fibrillation, et cetera. So
it's quite striking, actually. It wasn't that long ago, right, Darren, when,
right.
When you think of it, that we had just only 2 or 3 agents for diabetes, and that treating sugar was good for the eyes and the kidneys and the nerves, but really did very little for cardiovascular benefit.
Yeah, exactly. And so, I went to Duke, I went to Duke to get trained in cardiovascular clinical trials, got a master's degree, worked with Rob Califf, who was my mentor. Ultimately, he was the FDA commissioner. And I got involved in the development of registration clinical trials, of trials sponsored most often, if not always, in my career by drug companies developing novel therapeutics. And in 2008, we began being required to test these new therapies for cardiovascular safety at a minimum.
And I think that's where, when we look back, I think it's fair to say, Darren, that you were one of the early and most important architects in trying, for the field evolving to understand are medications that lower sugar safe and potentially effective for the heart. Now, it really brings me to the second question, and that is that, many of our patients feel that cardiovascular risk or cardiovascular disease or a heart attack or a stroke just comes out of the blue suddenly without any warning. But is it fair to say that there are sort of cardiometabolic underpinnings for many years that precede that and that they represent potentially modifiable risk?
Yeah, absolutely. Just like we know with LDL cholesterol, the earlier and the more intense we treat LDL, the better. Blood pressure, the same. And now we have classes of medications developed, as you mentioned earlier, developed initially to treat hyperglycemia, but now we have evidence of their cardiovascular efficacy. And it's not just after a heart attack or a stroke has occurred, but it's actually primarily preventing cardiovascular events. We'll talk a lot in this conversation about atherosclerotic cardiovascular disease, but we've gotten really interested, as you know, and you've led much of this field, heart failure and ultimately atrial fibrillation. We have a lot of cardiovascular complications of diabetes that we are really able to address ahead of the game before people actually have events and get sick.
Now, Darren, when you look at the totality of the evidence with GLP-1s, and I know you've been involved in the story from the early days with liraglutide and then semaglutide and many of the other agents that are emerging in the GLP-1 landscape, what has surprised you the most with respect to the cardiovascular benefits of this class of medications?
Yeah, it's a great question. I think a few things have been a bit surprising. One, we know the GLP-1 receptor agonists induce weight reduction for people with overweight and obesity. But what we found in all of the trials is that the cardiovascular benefits are appreciated by people independent of their baseline weight and independent of the weight loss achieved. And so there are a lot of benefits of the weight reduction associated with GLP-1 receptor agonists, but the cardiovascular benefit is not completely predicated on that. A second surprise is we've not been able to demonstrate an association of the cardiovascular benefits with glucose changes. These drugs, GLP-1 receptor agonists, reduce glucose, fasting glucose and ambient glucose. And again, over long periods of time, that's going to have benefits on microvascular disease complications, but we have not been able to demonstrate that any of the cardiovascular benefits are directly due to the glucose reduction. I think the third surprise, and it actually came from the SELECT trial of semaglutide in people with overweight and obesity who did not have diabetes but had prevalent atherosclerotic cardiovascular disease, how very quickly these drugs reduce risk for myocardial infarction and stroke and cardiovascular death. In the SELECT trial, and I predicted for years, and I was completely wrong. I predicted for years that if we wanted to show effects on those outcomes, we would have to follow people for 2, 3, 4 years, like we did in the LDL cholesterol lowering trials, before we could actually demonstrate a benefit. And in the SELECT trial, the curve separated almost immediately for cardiovascular death, MI, and stroke. And so these drugs are stabilizing plaque, not just preventing its development and progression, but also preventing its unstable clinical consequences. And, we can talk all day long about how these drugs are working. I think probably that very almost sudden effect probably has to do with inflammation. These drugs are potently anti-inflammatory, and we know that inflammation destabilizes plaque. And so when we see the risk for myocardial infarction improving within months of starting a therapy, it's not just preventing the disease, it's stabilizing it.
Stabilizing the process. Yeah.
Yeah. Yeah.
No, I think those that very well said, and I think that as you mentioned, the whole thesis that it stabilizes the rupture of plaques probably is the reason why heart attacks go down, and the need for bypass surgery, the need for angioplasty, for example, is reduced quite significantly with these agents. Now, as we close off, I have a couple of quick questions for you. One is, People and patients, when they're looking up information, often come across experts like yourself and others who talk a lot about MACE reduction. These drugs reduce MACE and they reduce MACE plus. And, for the uninitiated, Darren, what does MACE mean? And what should patients really think about when we talk about MACE reduction with these therapies?
Yeah, this term MACE has really been a product of the drug companies, honestly, and it's an acronym that means major adverse cardiovascular events. So I've spent decades trying to educate my cardiometabolic friends, even those in the drug companies, that cardiovascular disease is much more than atherosclerosis. But MACE typically means cardiovascular death, MI, and stroke, myocardial infarction and stroke. And so it's a very atherosclerosis-based composite outcome, really important outcomes that patients experience. But as we've talked a couple of times now, I'm encouraging the companies, put heart failure into your MACE definition, your major adverse cardiovascular event, because that's where we still have a lot of fruit to harvest to not get rid of, but to mitigate the heart failure risk of these patients.
So as we conclude today's episode, my gratitude to you, and of course, the gratitude of the entire community for leading the way, really a transformation of a therapy from a diabetes medication to a truly cardiovascular medication. And as you've said, a cardiovascular protective medication, regardless of your sugar, regardless of your weight. I think it's a new day. Do you think that the future of cardiometabolic disease is being rewritten here? You think the entire trajectory of chronic diseases can now be revisited thanks to some of the therapies like GLP-1s and SGLT2 inhibitors and many more therapies that are on the horizon?
Yeah, I think we are rewriting the playbook, right? And so 20 years ago or 30 years ago, when LDL therapies, statins were under the purview of the endocrinologist. And once we developed cardiovascular outcomes efficacy data, we as cardiologists adopted them as part of our critical group of medications that we're using to modify risk. And as we've gone through this evolution, one of the things we've heard over and over again is GLP-1 receptor agonists and SGLT2 inhibitors. I'll leave that to the endocrinologist or leave that to the primary care doctor. But that's like saying, I'm going to leave statin therapy to the primary care doctor. And, these drugs have proven efficacy for cardiovascular risk, and we're not necessarily embarking on glucose management. We're using a medication with proven efficacy for cardiovascular risk reduction. These are cardiologist medications as well as primary care and endocrinologists.
So when you've got a patient sitting in front of you, Darren, as a cardiologist, and you're telling them about a GLP-1 receptor agonist or another, an SGLT2 inhibitor or other therapies in the cardiometabolic space, what is the most important message to communicate to them about these therapies?
Well, that they have large, robust data sets proving their safety and their efficacy. Not everybody can tolerate them, but we coach the patients along those lines. We start very low dose and we titrate very slowly. And even if the person is not experiencing day-to-day benefits, maybe they're not losing as much weight as they want on a GLP-1. What we coach them is that doesn't mean the medicine's not working. And the reduction in long-term cardiovascular risk, we don't know what to measure on a day-to-day basis. So we just encourage them, just like a statin, just like taking their blood pressure medicines. We need to get on and stay on these medications as long as they're accessible and the person tolerates them.
Well, we've had a wonderful conversation with Professor Darren McGuire today about cardiovascular protection of GLP-1 receptor agonists. Please join us in the next episode as we take a deeper dive into GLP-1 receptor agonist and heart failure.